for being with me today. So I'm just going to start us off with a question. So what's new in fluid management?
Well, it's a great question. Virtually everything, which is what makes this so much fun and so exciting today. We have new ways of looking at the data and the risks around fluid management. So big data is giving us some insight to the risks around mismanagement of fluid. And there are many new studies coming on board, as we speak, that gives us more insight there. In addition to that, we have new technologies today by which we can go after the challenges associated with fluid management that we've never had before. And with those new technologies, we're really opening up new physiologies that we haven't seen before. So not only do we have new technologies, but we actually have a new understanding of how patients are responding or not responding to fluid that we've never seen before. And with all of that, it's really driving some very significant differences in patient outcomes. So fluid management is really a very exciting space today, more so than many clinicians, I think, realize.
That's exciting. How is that big data giving us new insights?
Well, the ability to look at large populations of patients is opening up new windows into the challenges and the risks around fluid management. I think as clinicians, we've always known that giving too much fluid is a problem, as well as not giving enough fluid. So that U-shaped curve of complications that we talk about, clinicians certainly in anesthesia and critical care, surgery, emergency room, we're very focused on under-resuscitation and not having enough fluid on board to support the circulating blood volume. We know that patients get into trouble there very, very quickly. So we've been very focused there at driving and improving outcomes by focusing on that area. Meanwhile, we've also known that giving too much fluid has always been a problem too. Having said that, though, oftentimes those complications don't show up for 48, 72 hours, and we're probably not tuned into those as much as we should be. Certainly when you look at the data around this and some of the data that's becoming more apparent, the risks associated with volume overload is really quite impressive. And so this value proposition of getting data or getting fluid just right is really supported by the data. And that window, that narrow window of getting fluid just right is probably more narrow than we've appreciated. And staying within that brings more value than we've ever seen before.
Yeah, okay. Interesting. So what new studies are showing that?
Well, there's some work that we've done with Paul Merrick that was published a little over a year ago now, where we looked at roughly 25,000 patients in a premier data set. And with that, what we were able to show was that fluid actually becomes an independent risk factor for complications. One of the earlier much of the earlier work has been observational in single center or a few multi-center studies. And the complication of fluid and patient severity has always been sort of intermingled, and the ability to tease that out has always been a bit of a challenge. And so it's unclear whether patients don't do well because they're sicker or because they got more fluid. Okay. But with these new studies and looking at the big data, we've been able to tease that out and build models where we can adjust for fluid, for patient complications associated with their disease severity and separate that from the fluid. And what we're seeing is that fluid actually becomes an independent risk factor for mortality. Okay. In sepsis, in this large data set, over about 5 liters of fluid, patients begin to experience increased risk with complications and increased risk in mortality over and above their disease severity. After about 6 liters of fluid, above that, mortality rises for about 2.3% for every liter of fluid you go over that on the first day. These large studies certainly are showing that this concept of being able to give fluid and then take it off later, frankly, that doesn't work so much. This has also been shown in the surgical literature. 36,000 patients undergoing abdominal surgery. Similar studies looking at this with the risk of fluid. Over about 5 liters a day of surgery, so this includes not only the operating room, but the recovery room, out on the floor. If you receive over 5 liters of fluid on your day of surgery, your mortality risk rises, and rises almost doubles after 6 liters. So all of this is really leading to some major, attention and focus on volume overload. There was a third study out of MGH and the Harvard system in Boston where they looked at 92,000 patients over a 7-year span. And again, they see these U-shaped curves that we all naturally assume with complications. But what was interesting is that fluid restriction leads to problems, fluid overload leads to problems. So it's really this value of getting it right is really important.
So you mentioned a new technology. How is that opening up new avenues into fluid management?
Well, I think, going back to why we give fluid, we've always given fluid to expand circulating blood volume and to support perfusion and circulation. And when we give fluid, the question we've always been asking is, what will the heart do with it? Will the heart actually improve cardiac output? Will it improve perfusion? And if you go back to the earlier days of CVP, even earlier days of echo, what we've always been using those technologies to predict is, what do we think is going to happen when we give fluid? Well, with the advent of stroke volume and cardiac output, non-invasive at the bedside, we no longer have to guess. Finally, after hundreds of years of guessing, we have the data right in front of us. We can actually look and see whether or not the heart responds to fluid. And that is very exciting. That just opens up a whole new window into the physiology and the understanding of fluid management. We've never had that before.
So you also mentioned seeing new physiology. So what do you mean by that?
Well, we're seeing a couple things. I think one of the things that's most striking, I think when clinicians give fluid, they believe that it's beneficial and they want to see it expand the circulating blood volume. When you actually look whether or not stroke volume increases when you give fluid, you only see that in about half of patients. That's interesting because you see that across multiple clinical settings, whether you're in the emergency room, whether you're in the operating room, whether you're in the ICU. You also see it across the technology. So this isn't technology specific or it's not setting specific. This is this natural physiology of preload dependence, fluid responsiveness. It is much more variable than what we have previously, I think, thought as clinicians. It's actually fairly challenging or provocative for clinicians to see this.
Right, so you're saying only half the time.
That's right. So multiple studies have shown, looking at even hemodynamically unstable patients, hypotensive patients, only about half of them will respond to fluid by improving their cardiac output.
And that's powerful because today we can see this at the bedside, actually.
Well, we can see this, and then you couple that with the understanding of the risks of volume overload. If you're not getting fluid expansion, if you're not getting improvement in cardiac output, the additional fluid that you're giving is simply going into the lungs or into the kidneys or into the liver, into the gut, and increasing fluid load and really not serving a benefit. In fact, may be very harmful.
Interesting. So are there other ways then beside cardiac output that gives us better insight into what's happening with the patient?
Yeah, it's a great question. I think not only are we seeing the whole concept of fluid responsiveness, but this is actually the other value that I think we're seeing when we start using stroke volume and cardiac output at the bedside to guide clinical management. Mm-hmm. We're seeing actually a physiology that we've known for a long time. You know, blood pressure has been easy to measure. We've measured it since the late 1800s, early 1900s. So we've had it around for a really, really long time. The blood pressure is easy to manage, and we know how to use it. But blood pressure is actually not a great indicator for perfusion because we know that vascular resistance and other things come to play to maintain blood pressure. Meanwhile, flow underneath blood pressure can be highly altered. If you think about patients that are critically ill in the ICU on very high doses of vasopressor, you may have an okay pressure, but your flow, your perfusion underneath that is very limited. One of the earliest studies, and I love this study, it's a great study, Barcroft did this in 1944 with, I think it was 7 Irish medical students. And what they did was they got these medical students to sign up for this study. It's much better to be a medical student today, I think, than in 1944. But back in 1944, the deal was this. They were going to bleed them until they fainted.
Nice.
Okay? Yes, very nice.
Okay.
Easy study to do. And they measured cardiac output while they were removing blood volume from them. And sure enough, what you saw was blood pressure held flat literally until the very end, until they fainted, then it fell off a cliff.
Okay.
But if you were actually looking at cardiac output, you could see it actually fall linearly early. So cardiac output, we know, is an early indicator of intravascular loss, intravascular perfusion problems. Another study that's more recently done on this, Cavertino looked at this, I think it was in 2004, and recreated this in Army Rangers. He didn't bleed them, but what he did was he put them in a lower body negative pressure suit. So basically acutely remove blood volume from the central circulation into the legs. And so it's a very good model for acute blood loss and sequestering preload. And sure enough, what they see there is quite fascinating. Again, known to us as clinicians, we don't sort of think about it on a day-to-day basis. But blood pressure up to about 1.5 liters of acute blood loss remained fairly stable. It didn't really change much, certainly not in the range that you would think clinically. It went from about 130 down to 115. And we see that all the time clinically. We don't react to it. But if you looked at the physiology underneath this, you see stroke volume fall dramatically from about 130 down to about 39. linearly, okay? You see cardiac output come down too, and cardiac output, of course, is mitigated because heart rate goes up a little bit. So stroke volume has the biggest change. And then, of course, vascular resistance is compensating to keep the blood pressure up. So you have all this physiology occurring underneath a very normal blood pressure. So I think the other value that these technologies bring is we have better views and better understanding of perfusion than with blood pressure alone. So actually, when we're monitoring people with these technologies, we're probably intervening earlier than we would with blood pressure, which I think also brings value.
Yeah, because what I hear you saying that the studies and the data is showing us is that blood pressure is really a late indicator of a worsening or developing perfusion problem, whereas stroke volume and cardiac output are really changing first.
Absolutely. And I would even go further than that, because I think when we think about how we measure and think about perfusion as clinicians, blood pressure we also use things like urine output, we use things like mentation, we use things like ECG, looking at cardiac function. All of those, and lactate for that matter, all of those are very, very late indicators. And certainly blood pressure is probably better than some of those, but those are all very late indicators of after organ damages or the organs are already struggling to deal with the lack of perfusion. So looking at stroke volume, trending stroke volume, really lets us see around the corner of blood pressure that we haven't been able to do before.
Nice, I like that. So what's the evidence then that this approach actually works?
This is where it gets very interesting and very exciting. There's evidence really in multiple fields that show this repetitively as you start to look at it. There's been a lot of work on this in the surgical literature in the perioperative space, really going back to the early turn of this century, 2004, 2005. T.J. Gannon group actually looked at some interesting outcomes, showed differences in length of stay, differences in pulmonary complications very early, with attention to stroke volume and stroke volume care during surgery. Noblet in the UK also looked at IL-6 levels associated with this and showed improvements. All this led to the Europeans, and certainly the NICE in the UK, to adopt and ask that stroke volume management of fluid be sort of the standard for the country back in, I think it was about 2010. More recently, the Fedora study was actually just published recently. It's a Spanish study looking at stroke volume guided fluid management. And again, they saw improvements in pulmonary function, reduction in perioperative wound infections, a whole series of reduction in acute kidney injury as well. So real significant difference in outcomes. Still, to this day, we see this. And then couple that with some experiences that we're seeing in the ICU and in sepsis. There was a recent study out of the University of Kansas that was done with the Cheetah technology, and they simply looked at septic shock patients as they implemented the Cheetah technology. And what they saw was reduction in length of stay by almost 3 days by using this approach to fluid management. One of the things that was driving that was probably reduced mechanical ventilation. Okay. The risk for mechanical ventilation was cut in half. The hours on pressor were also cut in half. And then also what was really interesting signal, and we see this in the Fedora study, we see this in other studies as well, is a reduction in renal injury. So the need for renal replacement therapy was cut by almost 2/3. So again, I think this is very interesting. Yeah, the kidney injury is kind of interesting because when I went to medical school, I was always taught that the kidney needed a lot of fluid and to make sure the kidney was adequately perfused. Sure. Actually, the kidney is probably, as an encapsulated organ, is very sensitive to high venous pressures and volume overload. Okay. And I think it's one of the things that we're seeing as this plays out. So this is not about too much fluid or too little fluid. This is really about optimizing it for the individual patient and getting it just right. With this, as I said, we're seeing outcome changes in the surgical literature, in the ICU literature, and stay tuned, this just continues to build. Yeah, this is very exciting.
That is very exciting. So then if we're building on this body of literature and we know that it's exciting, why do you think clinicians are so complacent about fluid management?
That's a great question. I think, first of all, clinicians are busy people. We have a lot of things competing for our mind share and our attention at the bedside. It's a busy space, whether you're in the operating room, the ICU, the emergency room, wherever you are. Clinicians are very busy people. So there's a lot of things we're balancing. I think we're actually pretty attuned to underperfusion and fixing that because we see blood pressure and we're wired into fixing that. I think one of the challenges for us on the volume overload side is that we're all wired to see things very quickly. We like proximal cause and effect. We like to do something and see the effect. fluid and the complications we're talking about actually occur at 48 and 72 hours. So we're really not wired to see them. We don't think about them as much. They're not top of mind as much. So I think that's one thing, and that's where you need to go to the data. When you go to the data, it's scary. We're talking about mortality. We're not talking about subtle changes. We're talking about mortality numbers with this. So I think that's impressive. And then the other thing is, I think quite honestly, we haven't had the tools and the technology, the equipment, to really make a difference and understand this. And that's what's coming online today. So I'm hopeful. I think clinicians, as we recognize the importance of this, it'll become more top of mind.
We're going to talk a little bit about how our technology works.
Sounds great.
All right, so let's just dive right in. How does our technology work?
So how do we get from 4 sensors on the patient to cardiac output on the machine? Okay, well that's a pretty straightforward question.
Love it.
First of all, it's both very elegant and very simple at the same time. So it's simple to apply and simple to use. It's literally 4 sensors that you place on the chest surrounding the heart and the great vessels. You want to create an electrical field around the chest. What we do with those sensors is we instill a very small high-frequency electrical current, and then we watch as that current comes back to the sensors, and we look at the changes in those currents. So we're creating this electrical field and looking at the changes. It's a little bit similar to ultrasound in that if you think about ultrasound, you apply ultrasound waves, watch them bounce back, and see how they change as they come back. Same sort of principle, only with electrical activity. And so that electrical activity changes in a couple of ways. It changes both in the amplitude, the height of the waveform will change a little bit, and then the timing of that wave changes. Our special sauce is in the timing of that wave, because that's where we look. And the main thing that causes a difference in the timing is the amount of red cells, the amount of blood volume in that box.
Okay.
So if you think about it with the cardiac cycle, the main thing that's changing in here during the cardiac cycle, which is where we're looking, is between systole and diastole, there's different blood volume in the chest. That, of course, the volume leaving the box would be the stroke volume.
Okay.
So we take that electrical signal, and we have looked in over 65,000 patient samples and correlated that to very well-executed, tightly controlled thermodilution to arrive at stroke volume. Okay. That's how we do it. And so, in essence, we're looking at the electrical signal change that is correlated to the blood volume that leaves the chest with each heartbeat, which, of course, is stroke volume.
I like that. Talk to me about some of the advantages of using this technology.
Well, I think one of the core advantages of using this technology is that it's very easy to use. Okay. So literally by placing sensors on the chest, you can hook up and have a cardiac output within minutes. The other thing I think that is a core advantage of this too is we measure centrally. So we're looking at the blood volume leaving the chest directly at the chest. We're not looking at arterial waveforms peripherally or other things that can be distorted from the chest out to wherever it is that you're measuring. So we measure centrally. I think those are the 2 really sort of core advantages of the technology.
Okay, so I don't need an art line.
No,
okay.
Absolutely not. The other thing is with this, since we're not arterial waveform based and not respiratory based, we measure through dysrhythmias, any type of changes in the cardiac cycle we catch. We'll show you what the actual cardiac output is through those episodes.
So AFib?
AFib works fine.
Okay, yeah. All right. So then conversely, talk to me a little bit about what some of the limitations are.
Sure. It's a great question. I think, as I said, we create a box around the great vessels in the heart, and we look at everything leaving that box as cardiac output, as forward flow. There are some situations where you have backwards flow out of the heart. We would certainly see that as forward flow, so in those situations, we potentially would overestimate cardiac output. Likewise, if there are intracardiac shunts that are occurring, we see blood leaving the chest, not necessarily the circulating blood volume. So depending on how you're measuring it, is important for comparisons.
Okay. So here's another question for you. Let's talk about accuracy. I know we mentioned a little bit about thermodilution, but can you talk to me a little bit more about how really accurate is this?
Sure. Well, I think one of the things to make sure that we differentiate, when people say accuracy, they usually mean a couple of different things. One is the ability to compare it to a gold standard, so 2 technologies and how closely they compare. And then the other thing is that with repeated measurements, how likely are you to get the same measurement? So a ruler, for instance, is very precise. If you take a ruler and you're measuring for 10 inches against something, every time you apply that, you should come up with very close to 10 inches. So that's precision.
Okay.
So accuracy against a gold standard, first of all, that begs the question is, what's a gold standard?
Sure.
Okay, and so the gold standard in clinical use is often the Swan-Ganz catheter. A lot of us have grown up with Swan-Ganses, certainly I have, and we've become very complacent and sort of understand how a Swan works. We think of that as a gold standard, but the Swan actually has very poor accuracy as well as precision when it's compared. Swan-Ganz, the accuracy is impacted by how the catheter is placed. Is it in the right place? Are you using the right amount of injectate? Is there any tricuspid regurg? There's a whole bunch of things that come into this. Temperature, exactly. All those things come to bear with how accurate the Swan-Ganz is. Likewise, the ability to be precise, so repeated measures.
Sure.
What we do know with the Swan-Ganz is that it can be 15 to 20% differences on measure over measure. In fact, it takes 10 well-done measures to get down to about a 10% variability on the Swan-Ganz. So we tend to forget that in clinical use just because we've gotten used to it. But when we look at the Cheetah technology, okay, and this is tested against aortic flow probe in open chest animals and tests very, very well. We have accuracy against aortic flow probe of about 6%. So our mean bias, our mean difference between aortic flow probe measurements and ours is actually quite good.
Wow, that's good.
Similarly, with precision, the ability to repeat measurements and get the same measure against the aortic flow probe is roughly about 6.1%. So from a precision and accuracy perspective, our technology is actually very, very good. Where we get into problems and challenges with clinicians, and clinicians sometimes will question the accuracies when they're comparing against other technologies, which frankly are not as precise and not as accurate as our technology, yet they believe them to be.
Right.
And so we end up challenging a lot of paradigms when it comes to accuracy and precision. But the technology is actually very good. So we've been validated against all of the major technologies, and we're happy to go head-to-head with any of the technologies if need be.
Nice. So we sometimes hear mistrust around all the non-invasive technologies. Why do you think that is?
That's a great question. I think several things come to mind here. I think clinicians are naturally cautious and skeptical, as we should be.
Sure.
So I think that's just in our nature. It's the way we approach the world, which is a good thing for our patients. That's not a bad thing. I think the other thing, though, too, is if you think about it, this is almost magical. You're placing sensors and we're getting a cardiac output.
Right.
I grew up in the days if you had to put in invasive lines, this was a big procedure, and suddenly I can get this off the surface of the chest. How does that work?
Absolutely.
And so I think there's a lack of trying to understand how it is that we do that. And then I think the other thing is that these technologies, we talked about this really being this nice march of technologies. A lot of the earlier technologies on the market had some marked limitations to them, and I don't think we understood them as well. Certainly clinicians didn't. Pulse contours had problems with vascular resistance changes, and so when used in those settings, it becomes less accurate.
Sure.
Echo Doppler has to have the optimal signal. If you don't, it becomes less accurate. So there are ways these technologies become slightly less accurate, and if you're taking them outside of their ranges and their ability to execute there, you'll be disappointed in that. So I think there's been, it's been a variety of things. The nice thing about bio-reactance is that those limitations don't exist. We measure centrally, so we're not impacted by vascular resistance changes or changes in an arterial line. We aren't impacted by respiratory changes. We're not impacted by dysrhythmias. So all of those things, our technology is very robust and has the ability to play through all of those.
Talk to me a little bit about dynamic measures and dynamic assessments. What are they?
It's a great question. A dynamic measure is really what we've been looking at and what we've been searching for a long, long time. Basically what it is before we give fluid, we want to test the heart to see what's going to happen when it receives fluid. So a dynamic measure is very simply, it's a small challenge to the heart and watching how the heart handles that response. Does it increase stroke volume by more than 10%? If so, that is highly predicted that when you actually go ahead and give additional fluid, that you'll get a sustained rise in cardiac output. If the stroke volume index does not change by more than 10%, it is highly unlikely that when you give fluid, you'll actually see a sustained rise in cardiac output. So it's really a measure of whether or not fluid is going to be effective at improving cardiac output and helping you improve perfusion.
That sounds very straightforward.
Indeed.
So then why is a dynamic measure better than the quote-unquote, old way of assessing a patient's fluid needs?
Well, I think the dynamic measure is what we've always wanted. It's what we've always been searching for. It's just until we've had the ability to look at stroke volume change, cardiac output change at the bedside non-invasively, and we've had technologies that have the precision down under 10% that let us do this. We haven't had access to this before.
So what are some ways of actually performing a dynamic measure?
One of the easiest ways is actually, and it demonstrates the physiology really, really well, is doing what's called a passive leg raise.
Okay.
So if you actually raise both lower extremities, you get about 250 to 300 cc's of blood in an average size adult, quickly coming back to the heart. So when you do that maneuver and you get that 250 to 300 cc's of blood coming back, watching what the heart does with that and whether or not it actually increases cardiac output is one of the ways of executing a passive leg raise.
Okay.
The beauty of this is you put the legs down, fluid goes back, no harm, no foul, no additional fluid. It's a very good diagnostic test. In fact, it's been very well studied. And when you look at the statistics around this, the sensitivity and specificity are both in the upper 90s.
Oh, wow.
The receiver operating curve, which is another statistical measure, is over 0.9. This is a really good performing test when it comes to predicting whether or not patients are going to have a sustained rise in cardiac output with fluid. In fact, it's performing at the level of tests that we use commonly all the time, such as serum creatinine, thyroid function test. In fact, it's on the order of troponin as far as sensitivity and specificities in predicting
So very
response.
accurate.
It's very accurate.
Very accurate.
Yeah.
So then what happens if I can't do a passive leg raise for some reason?
Well, you can mimic the physiology. So you can mimic that by giving an extrinsic fluid bolus. So actually, providing the patient with a small fluid bolus. Now, what you want to do when you do this, though, is you want to mimic the physiology of a passive leg raise.
Okay.
So if you think about with a passive leg raise, the fluid translocates in 2 to 3 minutes. It's very fast.
Right.
So if you're giving an extrinsic bolus, you want to give that very quickly as well. This isn't over 15, 30 minutes. This is over 2 to 3, 5 minutes, a very quick fluid bolus. And watching what the heart does with that. And again, if the stroke volume goes up by 10% or more, it's highly predictive that you'll see a sustained rise in cardiac output. If you don't see that 10% rise, then it's highly unlikely that the patient will actually have a sustained rise in cardiac output with additional fluid.
So then my next question is, what if I'm with a very critically ill patient and I simply am, or in an emergent situation, what do I do if I can't do a leg lift or I don't have time to spike a bag and put it on a pressure bag?
Sure. Well, of course, what you want to do is take care of the patient and stabilize the patient. I think, in those settings where you're giving fluid and an active, resuscitation, if you can get the cheetah monitor on, if you can get the sensors on and watch, you can actually see, are you seeing a rise in cardiac output, a rise in stroke volume with the fluid that you're actually giving? So is the fluid working? Of course, what we typically do in those situations is we do a mix of fluid and pressors.
Sure.
We do what we can to get the patient stabilized, and you certainly want to continue to do that. I would say, once you get the patient stabilized, then you can also look at how do you titrate therapy and adjust fluid versus pressors. It's a great time to come back and revisit fluid responsiveness.
So really, there's no time when you couldn't use cheetah. You could trend, you could do a leg lift, or you could do a bolus.
Absolutely.
Okay.
And I think
wide application.
Yeah, exactly. And so, the thing here is what you want to be thinking about, is the fluid that you're giving effective?
Sure.
So you can do a diagnostic test up front to know before you give fluid. If you really are committed to giving fluid, you can also check and see, is the fluid having an impact? Is it having the right effect?
Sure.
So it's, diagnostic versus watching, is your therapy effective?
Okay. So then talk to me about who's endorsing this approach.
Well, the dynamic approach, again, I think is the physiologic approach we've been striving for a long time. We've been looking for it. And really only with the advent of these technologies at the bedside can you now get there. And that's very exciting. Some of the earlier endorsements, NICE in the UK endorsed this in surgery back in 2010, approach of using dynamic measures to guide fluid responsiveness. The European critical care societies began to endorse this shortly thereafter in 2011, 2012. Here in the U.S., CMS has adopted it, endorsed it in their sepsis measures, and of course the Surviving Sepsis campaign also endorses the use of dynamic measures and this physiologic approach to guide your fluid management.
So worldwide then?
Yes,
Okay.
yes.
All right. When should I perform a PLR on what type of patient?
It's a great question. It's a question we get frequently, I think. Anytime that you are wanting to give fluid as therapy, that you're trying to improve perfusion of a patient, you're trying to fix a blood pressure, trying to fix a low urine output, or ECG, a high lactate, whatever it is that you're trying to improve the perfusion by giving fluid, you want to check and make sure, is that fluid going to be effective? Or as you're giving it, is it actually having the impact? So that is the time where you want to intervene and actually check, is the fluid going to be effective? If it isn't, then you want to think twice before you continue to give fluid, because we know the complications associated with fluid overload and volume, the ability to sort of load them up and take it off later, that doesn't work so much.
Sure. So then how often should I be repeating that assessment? If I'm going to be doing a dynamic assessment and I do a leg lift, let's say I intervene, I end up giving my patient fluid because they were fluid responsive, when do I come back and recheck?
I think you come back and recheck when you're concerned about the perfusion of the patient. And if you're actively managing the patient's perfusion. If the blood pressure is okay, the cardiac output is okay, and all that, you're not going to do anything, there's no need to intervene. You don't necessarily need to check. But certainly if you're looking at, can you substitute fluid for pressors, you're trying to adjust pressors, it's a good chance to look, is there a time where you want to give additional fluid? You should be thinking about checking to make sure that the dosing of that fluid is going to work and it's going to be effective. That's when you do it.
Okay, that helps. So this is non-invasive, and a leg lift is also a non-invasive maneuver. To me, as a nurse, this can be entirely nurse-driven.
I think it's a great point. And what we see typically with customers, this gets written into protocols, it gets written into orders. Anytime that you're giving a fluid bolus, check first.
Nice. How should I use the other hemodynamic data that the monitor is providing?
It's a great question. I think we're really not asking you to change your clinical approach to patients. What we're really talking about is better informing the decisions you already make. Because if you think about what we do in the ICU, or in the ICU, in the OR, the ED, we're managing patients' perfusion and blood pressure and making sure that patients are stable and doing well. The first decision there is, do I have a perfusion problem? We can help with that. In addition to blood pressure, as we talked about before, cardiac output adds something to blood pressure, lets you see the physiology underneath blood pressure. But then, if you do have a perfusion problem, typically our first go-to agent is we give fluid first. Okay? What we're really talking about now is we can help you see whether or not fluid is effective, whether or not fluid is getting you what you want it to do. And that's important because the literature is showing us half the time it's not working in that regard. And what we also know is that volume overload and giving too much fluid is also problematic. And as I said earlier, this ability to sort of load them up now and take it off later, that doesn't work so well. That has mortality implications. It has complications that I think we tend to discount a little bit. So what we're really talking about, is fluid effective? If fluid is not effective at getting your perfusion fixed, then typically we move on to pressors. And we can help you here with vascular resistance and looking at the impact of your pressors. And then, of course, if your cardiac output is low for some reason, ionotropes or other therapies directed at contractility can work as well. So we really help inform all of those decisions as you move through that. But those are decisions that we're making every day at the bedside, in the ICU, in the ED, and the OR. So we're really talking about how do we better inform those decisions. It's not really making anything different. It's really about better information.
It's really enhancing and giving a window into the heart that we couldn't see before.
Exactly.
I like that. Let me ask you just one final question, Dr. Hansell. Do you believe that fluid is a drug?
Well, I think, yes, I do. I think the issue with fluid is we tend to discount it. And it's running all the time in the background. It's something we've gotten used to. But certainly what we see is that I don't think it's that different than giving morphine or giving Levophed, quite frankly. We know if you need those drugs and you don't give enough, you don't have the impact. Underperfusion is a problem. If you don't give enough fluid, patients remain underperfused and they get into real problems with that, significant complications. Likewise, if we give too much of a drug, we get into side effects and with volume overload. So getting fluid right I think, is actually really critical. And what we're learning is getting it right is actually a narrower therapeutic window than we've appreciated in the past. Because part of the problem is the complications on the volume overload side we don't see for 48 or 72 hours.
Sure.
And we tend not to, I think we tend to discount those a little bit. So this value of getting it right is absolutely critically important. We do that with all of our other drugs, our antibiotics,
Absolutely.
our vasopressors, pain medicines, all these things we titrate very carefully. I think we'll do better by titrating fluid more tightly for patients and better for patients. Certainly the outcome data in the surgical literature and the ICU are demonstrating that.
It sounds like what I hear you saying is that you really can't afford not to check.
I think that's absolutely spot on. We don't, any other drug that we give, we always check the effectiveness of that drug. Think about that. We should be doing the same for fluid. And we have the tools to do that today.
I agree with you. Thank you so much for your time today.
Thank you. It's been a lot of fun.